Welcome to the Pharmacists Are In, a podcast made for pharmacists by pharmacists, hosted by John Papasturjo. John is a frontline community pharmacist owner, assistant professor at the School of Pharmacy at both the University of Toronto and University of Waterloo, and an internationally recognized speaker, author, and researcher. Today's guest is Debbie Rigby, who has practiced in hospital pharmacy for 20 years. Debbie initially specialized in oncology. Later, she practiced as a drug information specialist in the hospital environment. Debbie was also recently nominated as one of the 12 agenda setters in the Australian pharmacy sector. Join John and Debbie as they discuss the place of Australian pharmacy as one of the world leaders in expanded scope, from immunizations and medication reviews to advocacy on pharmacists' prescribing rights. Learn how Australian pharmacists take on new and exciting responsibilities. Debbie's long history as a pharmacist offers up insight on how to succeed in scope expansion. Pull up a seat and let's get started.
This time I'm here with Debbie Rigby from Australia. Welcome, Debbie.
Thank you.
Yeah, it's good to have you here. So I love FIP, get to talk to people from all over the world. It's a really awesome scene. And tell us a little bit about pharmacy practice in Australia.
Well, I think listening to conversations and presentations here at FIP, it's pretty much the same the world over. I think we've got some real advantages in our funding of various programs and services through what's called the Community Pharmacy Agreement, which is an agreement between the government and negotiated by the Pharmacy Guild, which represents pharmacy owners. But there's a whole range of services. The one that I guess that I've been most involved with is home medicine reviews.
Okay.
And prior to that is residential medication management reviews, RMRs.
Yeah, I remember early in my career, started to dabble in practice research. A lot of the papers I would pull were from Australia. So right. I think of Australia being a little bit ahead of most countries, and reimbursement definitely part of it. But before we get to that, how about your career specifically? Community pharmacist, hospital pharmacist, what exactly do you do?
A bit of everything, really. I always say, especially to students or younger pharmacists, I wouldn't have imagined what I do as a pharmacist when I graduated 40 years ago. So my career's sort of been two halves. The first 20 years mainly in hospital pharmacy. So I started there, I was sort of specialised as an oncology pharmacist for a number of years. And then I had children, or started having children, and went back sort of part-time doing drug information in a couple of different hospital departments. So I think that ignited my passion for drug information, for knowing the literature, knowing the evidence, applying and interpreting the evidence there.
Yeah, it's one of those things. I mean, I think, you said you didn't imagine what you'd be. Same with me. I mean, I thought I was going to be a hospital pharmacist for sure. I said, well, that's where all the good clinical work's done. That's where I'm going to go. I found in a couple of years, I was really felt like in Canada, especially, I felt in hospital, I was really restricted as to what I could do. I mean, I'd have a good idea, but there's 100 committees you'd have to go through and whatnot. Right, yeah. So then I ended up in community, and then, I started to take all those little things I learned in hospital, and I started to apply them to community. And I said, wow, this is like a blank slate here. I could pretty much do whatever I want. And it just snowballed from there. I mean, we're here doing a podcast today, but I mean, my students ask me, they're like, how did you get involved? And I go, really, you don't know. It just happens, Yeah. And I think the message I have for them is don't pass on these opportunities.
Yep, absolutely.
And check a lot, try different things. I mean, you may think you're going to do one thing, but end up totally somewhere else. But are you still as passionate about the profession? I know worldwide we've had a lot of drug reform. You hear about some of the challenges pharmacists are facing. Being in the profession for so long, are you still excited about it?
I am actually. We've just had this sort of a poll in Australia through one of our pharmacy journals and media, where the readers, there's about 30,000 pharmacists in Australia.
Oh, okay.
And readers of this daily e-newsletter type thing had to nominate the agenda setters in pharmacy. So, it's like any vote, it's a bit of a populist vote, but also just recognising the people that are setting the agenda, doing different things, being innovative, making the most of opportunities, as you say. And I guess I was very privileged to be one of the 12 people that were nominated. And it was such a mix of different age groups, different practice settings, but people that are doing interesting things, innovative things in different workplaces, you know, the hospitals, community. I work in a general practice as well, and that's really kicking off in Australia now, sort of following the UK model to some degree, as well as the Canadian, what they've been doing. So, I think there are lots of opportunities. There's lots of people trying to hold on to the past.
Sure.
I know in Australia, when I first started, owning a pharmacy really was a licence for money.
Sure. Yeah.
But the remuneration is nowhere near relatively the same. And the expectations of consumers, of the health system, of our interactions with GPs has really shifted, and I think that's good.
Yeah, I think the trend worldwide now, and what we're seeing is that, you know, dispensing margins are just eroding. So, I mean, if you're caught in that old mentality and you touch them, you just can't make up for it anymore.
Yeah.
So it's about looking at new scope, you know, reinventing ourselves a little bit. I think that's the only way forward. It's a quick race to zero, I think, in pharmacy
Absolutely.
margins. We've lost in Ontario this year about $200 million, I think, in drug reform, and it's not the end. Next year we'll get more.
Yeah.
The way we're responding is centralization. So the dispensing service is going to be totally centralized. We already centralized compliance packs. I think refills will come next. What I tell the young pharmacists is, listen, if you're tied to dispensing, you got to really rethink, you know, what you want to do, because I think that day-to-day dispensing task, it's gone. I mean,
Well, we've got a lot of robots in Australia
Sure.
now. Most of certainly the bigger pharmacies would have robots, and that does take away that sort of technical role, but it allows us to focus on the clinical role, the communication with patients, interactions with prescribers, with GPs.
how is the scope of practice? Could pharmacists, say, prescribe in Australia, or could they immunize? Like, what are they doing?
Just in recent years, as in the last 2 years, I think, we've had immunisation. A lot of opposition from the medical organisations, but reality is, and we have a national immunisation program where various children, as well as older people and other sort of specific groups of people, will get their immunisation for free, so including influenza vaccine. But doing the immunisation through community pharmacies has really picked up a whole cohort of people that haven't been, especially the flu vaccine. But also, like, for example, I've just become a grandmother, and getting your whooping cough booster is as a grandparent. So, it's filling the gap rather than taking over.
We have data too now. I did some work in this area where we didn't really take away from the physicians.
No.
If you look, the net amount of vaccines is still the same for them. We just added to it. And it seems like this anywhere in the world, it's the same thing. We're going to get some pushback. In the end, it just kind of gets accepted, right?
Yeah.
So I think pharmacists as a group, I think we've always historically been a little bit kind of more calm. We don't like a lot of, opposition. But the reality is, I mean, we're doing the right thing for the public, right?
Yeah, absolutely. It's population health.
That's it.
Statistics. We're just going through, we don't have pharmacists prescribing in Australia, but there's certainly been a lot of research, a lot of advocacy around that. And our current president of our pharmaceutical society has set a goal that by 2020 pharmacists will have prescribing rights.
Wow, that's pretty, it's not too far away.
Not that far away.
See, in Canada, again, it depends what jurisdiction you're in. So in Alberta, the pharmacists have full prescribing. In Ontario, we're able to adapt prescriptions and whatnot, but not prescribe. Other provinces now have minor ailment prescribing. So it seems it starts, one way and then kind of builds up to that. But I mean, ideally that's where we all want to get. I mean, it's going to take a while, but 2020, that's cool, ambitious too. Yeah, it's awesome. You touched early on a little bit on home visits, and I'm really interested in that because I did some work early on in my career, and Australia kept popping up every time I looked at home visits. Tell me a little bit about that.
Well, it's actually 20 years now. I was offered an opportunity to do work in some nursing homes, we call them, or aged care facilities. And that was back in 1994. And it was a different funding mechanism to the aged care facilities by the government. And it was on an annual basis. And if they hadn't used up their funding, they lost it.
Sure.
So we had an innovative, it was actually an accountant to aged care facilities, and he said, what can you do in the nursing home? And initially we were giving lectures to staff as well as to residents. And then I said, I guess from my hospital background of doing medication reviews and chart reviews, I just started sort of look at the charts and what patients or residents were taking, and started doing medication reviews. And we certainly had some pushback from GPs, and then in 1997, and that grew, so myself and another pharmacist, we actually had about 6,000 beds that we were servicing, going out to see. And then in 1997, we had government funding for it. And that continued to grow. We had another half a dozen pharmacists doing it. And then I thought, what about people in the community? We know even back then we were starting to talk about an ageing population and chronic disease burden. And 2001 we negotiated funding. It was really a pilot. I was involved in the very first pilot, peer reviewing and mentoring the community pharmacists that were doing it. So that established a research base, a cost effectiveness. And as I said, the funding started, and at first it was relatively small amounts of money, but as it rolled out and we did further cost-benefit allowance evaluation, it just grew. And the funding now is pretty good, I think, commensurate for the type of work, the number of hours and the responsibility.
We get, in Ontario, it sounds like you're a pioneer in this area, because I think we, came much after that, but we get paid $150 to go do a home visit now. Mm-hmm. So, I mean, it counts for the time to get to the homes. Yeah. It's always longer than you think, I think.
Yeah.
You get to some of these homes and you think you're going to turn around in half an hour. It never happens because, once the patient, I find, gets comfortable enough with you being there,
absolutely,
they pull out everything. You must have some interesting stories.
And the dynamics change. You're in their home. And even though, because I don't work in a community pharmacy, most of the time, vast majority of the time, I don't know the person.
Yes.
So you're invited into their home, and I think that's very special.
Oh, yeah.
And the dynamics change, and I start the conversation, whether it's about the weather or the football or their cute little dog or something, just trying to connect with people so they, and then let them tell their story. Sure. Rather than just, I guess I've changed. I've been doing it for 18 years now. I used to delve straight into the drugs, but now I start with saying, do you have any concerns around your medicines? And some of them just, you are there for an hour because they want to, but you pick up so much stuff, seriously. And
you must have some good stories.
Yeah, I've got some good stories. One of the stories that I say a lot is I'm on quite a number of committees, and I was actually in Canberra, our capital of Australia, in a restaurant in Canberra, and I actually just went to the bathroom and the then health minister was there too, so I introduced myself to her, and she asked what I was doing, and then I told a story, and it was a real story. The day before, I was in an elderly lady's home, and she was on warfarin, an anticoagulant, and she, so I asked where does she store her drugs, and she had a little dog. So she had this bundle of medicines she was taking, including her warfarin and including the dog's heartworm tablets. So it turned out she was taking the dog's heartworm tablets, and the little dog was getting her warfarin.
See, people don't get, and the only way you're going to figure that out is if you go to their homes.
Yeah.
We call it like we call them hidden in home kind of DRPs or drug therapy problems. But same thing with us. We would go into these homes, and like I couldn't believe the stuff we were finding. Patients would have their neighbor's medications labeled with their name, and they're like, "Oh, my neighbor gave me to this." I had a guy, he had asthma. And his neighbor had told him if he had crushed his osteoporosis meds and inhaled them, it helped with his asthma. And that's what the guy was doing. I'm like, are you kidding me? One of the things in Ontario that we have to do is we got to do part of the medication review to get the reimbursement. You have to do a medication cabinet clean out. And so we have to bring this stuff back. Like, my guys come back with bags of stuff, and you got to get consent. A lot of times the seniors will pull it all out, and then they're like, you know what, I don't want to part with it. I'm like, what do you think? It's like from the 80s, right? But they get really attached to some of these things. But I wish more, and in our experience in Ontario, is the reimbursements there, pharmacists still haven't fully embraced it. And it's been a few years. There's a group that will do it, and they do it very frequently, but there's still this group that's hesitant. I don't know if it's, the challenge of setting it up, maybe we're not used to getting out of it. But what are some tips? I mean, as someone that's been doing it for so long, if you're a new pharmacist and you want to kind of jump into this as a new area of practice, what would you tell them?
I think, be confident in your knowledge for a start. I go in with an attitude that I'm going to learn from the patient. Learn how they cope every day living with these chronic diseases, taking, in many cases, so many medicines, including complementary medicines that they'll buy from health food shops and pharmacies. I think the biggest lesson we've learnt in Australia is to establish the relationship with the GP, with the general practitioner. Don't just go in there and, with our home medicine reviews, you have to have a referral from the GP.
Okay.
But with the aged care facility, the RMRs, you had a contract with the nursing home and you did it. And that created a little bit of angst with the GPs because initially they weren't funded for responding or interacting with you. So we learnt that lesson. So when HMRs started, the GPs also got a fund, a certain amount of money. And it was really, money for writing a referral, but nevertheless, it really helped it take off.
Yeah, open the door.
So building that relationship with GPs and sometimes you just have to get one win with them for them to see the value. And often it's not about inappropriate prescribing, it's about what the patient's doing in their home. Yeah. Whether it's a adherence, compliance issue, taking the neighbour's medicines, the dog's medicines, the complementary medicines. Or not taking their own. Right?
Yeah, for us in Ontario, we're limited to homebound patients right now. So they're patients that couldn't otherwise come to the community pharmacy. So we had done some early work. We kind of, we published that paper probably about 5 years ago. And on average, pharmacists were identifying, I think, something like 3 or 4 DTPs per patient. During that time, we kind of had this hypothesis, because as we were enrolling patients for that study, there was like a group of patients, they weren't homebound. A lot of times you could tell they were probably worse than the homebound patients because they didn't have community care services coming in, they didn't have caregivers. So we kind of had this idea, what would happen if we went into the homes of those patients? So there are ambulatory, still coming to the pharmacy, but you just know there's more going on with that base. So we ended up, in this paper we just submitted actually, it was funded by Canadian Foundation for Pharmacy. And what we found, that group was actually worse off. We identified more DTPs, and it's because they really had no one else watching over them, right? Yeah. So I think, you touched on it, and I really believe it. You get into that home, and it doesn't matter who it is, you're going to find something. And I'm hoping they open up reimbursement, but it's going to be, the money's tight.
I can honestly say, I used to keep a real track of it, but I've probably done about 10,000 HMRs.
Oh, wow.
And I can honestly say that I've always felt I added value to the patient, to the GP, found something that helped the patient just living with these chronic diseases, taking medicines, inappropriate prescribing, sort of prescribing cascade where they see multiple doctors and prescribed one drug to treat the side effect of another drug. Drug interactions, which is another one of my interests, identifying that, but also giving the GP a solution. What are the options? Well, how can you manage that drug interaction? Maybe change it to an alternate drug that's not going to interact. And then similarly, the list of drugs that the GP gives me in the referral, again, is
totally different.
100% of the time has not been accurate.
That's right. Yeah, no, huge opportunity. Kind of switch gears a little bit. One of the other things, I know because you've done a ton of practice research, you're interested in this, so am I. We sit on a committee where we have kind of like-minded pharmacists that are interested in research, expanding scope together. How do we get more community pharmacists doing this? Historically, a lot of the research came out of the hospital setting, and that's great, or the academia. But when we're talking about real-world evidence, how do we get more pharmacists involved? It's a challenge, and we're all faced by it.
Well, everyone's time poor,
Yeah,
and I think that's a challenge, especially for community pharmacists. We have, I guess, with our undergraduate pharmacy degrees, they have QUM placements, quality use medicine placements. And I know I've used over the years these students that might be there for a 6-week placement to start to do some of that practice research, whether it's a survey or something really specific. I'm also an asthma educator, so I've had a lot of students to, sit down, really assess a patient's inhaler device technique, which quite often people say, oh yeah, I've used it for years, I know how to use it, sort of thing. And we all know 90% of people don't use them properly. Yeah. So, those sort of things. And that starts the enthusiasm and the interest in students, and then hopefully they can translate that into when they are practicing themselves. But I think one of the other things Australia's doing is what we call advancing practice. So you can get a credential and recognition as an advanced practitioner.
Yes, I've never heard of that actually.
And it's across a number of domains. It's not you have to submit a portfolio which is assessed by trained evaluators, by your peers, and you can be assessed at 3 different stages. I was part of the pilot and very fortunate to be in the first 28 in Australia that were assessed as an advanced practitioner. And part of that was across a number of competency domains, one of which was research. And now I'm not an academic, I've been involved with research, but I haven't got a PhD or whatever. And it was really helping people to understand you can do research, might not lead to a randomised controlled trial or your PhD, but we can all do practice-based research.
And it adds so much value. It's funny you said that, because I remember, early in my career, I said, it started my first ever paper. I look back at it now and I'm like, oh man, this was horrible. Yeah, how did I even write that? But I remember it was a really small kind of qualitative study looking at, could we do A1C screening in the community pharmacy, and what were pharmacists doing with the results? It was a point of care machine. It was called the A1C Now. And I remember it was just so poorly done, written horribly. I submitted it. It got accepted like that. And now I know the editor of the journal, and I asked him back then, he goes, because no one was ever submitting anything. So you get something from community pharmacy, you send it in. I guarantee you it's going to get accepted somewhere, because there's so, little work being done from community pharmacists. And to your point, it doesn't have to lead to a randomized trial, but it adds to the body of knowledge out there.
Right.
And that's so important. So if you had kind of, one message to say to kind of those new pharmacists, we talked about a lot of things, professions changing, what would you tell them?
I think make the most of opportunities. Things will come along and you think, geez, that's interesting, and try to embrace it and do it. And I know, we've all got to pay mortgages and feed our kids, etc. But if you can make the most of those opportunities when they present, but also networking. I think networking. I'm a bit of a conference junkie. I go to a lot of conferences. I speak at a lot of Australian conferences. Here in Glasgow at a magnificent conference with, meeting and creating friendships and colleagues from around the world. So that and the passion for keeping your knowledge up to date, lifelong learning. Drugs. When I started, most of the drugs didn't even exist. So if all you rely on is what you learnt at uni, you're not going to become a good practitioner. So, just those opportunities and to be the best pharmacist you possibly can.
That's a great message. Well, thanks, Debbie. I know you've mentored a lot of students. I consider you one of my mentors. I think, being able to sit and chat with you, I've got a lot out of it. Hopefully our listeners enjoyed it as well. And enjoy the rest of the Congress. I'm sure we'll be on the boat tonight as well.
Mm-hmm. Thank you. I've enjoyed it.
This podcast was brought to you by IPACT, the International Pharmacist for Anticoagulation Task Force. Visit www.ipact.org for more information.